Hello, kidney warriors. James here from Dadvice TV, your online kidney health coach. And this is the latest episode of Dadvice TV Live. We are 1 week before Christmas in December of 2024, if you happen to be watching this live. And today, my co-host, someone you guys all know, is going to talk about what to do when your kidney function keeps dropping. It's declining. What should you do now? What steps should you take to help try to put the brakes on and slow that decline of kidney function? Now, my guest, you guys know him, you love him. He is the author of my favorite kidney book called Learn the Facts About Kidney Disease. In my opinion, this is by far the book for kidney patients. It's very easy to read. It talks about what you should focus on, what you don't need to worry about. Talks about diet, all sorts of information in there, and it helps you better understand when is the right time to start dialysis. Because the author, Dr. Rosansky, wrote this because so many people were getting put on dialysis too early, and that impacts your quality of life. And data shows that if you're getting on it too early, it's not doing you any benefit. All right, so let's go ahead. Let's bring on my guest, and he's going to talk about the what to do when your kidney function is declining, and we're going to answer your questions from the audience after he's done talking. So go ahead, fill those comments up with lots of great questions so that he can get to them while he's here. Please give a big warm welcome to Dr. Steven Rosansky. Hey Doc, how you doing?
I'm good, James. Good, James. I'm hi to all of your viewers, and it's always great to be on your show. It's always great to see you, and I hope, as we have in past shows, help some of you folks who are concerned about kidney problems to be less concerned or have some better ideas of how to manage it. And yeah, today we're going to talk about. Well, first, you want me to introduce myself, I guess. Is
Yeah,
that
that way
okay?
people know why to listen to you, that you're not one of those quacks out there pushing some fake pills and fake cures.
Yeah, well, I respect James highly, and James is someone who could probably have made a ton of money by pushing some of those fake cures and things that people advertise online, which are, kidney baths and kidney, all these kidney nonsense things, people with white coats trying to sell you all kinds of nonsense, pushing these protein supplements for very low protein diets, so many things that are frankly dangerous in many cases. All right, so my background is taking care of kidney patients and general medicine patients for over 40 years. I started the kidney program in Columbia, South Carolina at the VA. I also published a good bit of my own research, have over 100 publications. I wrote the book that James told you about after being a little bit frustrated that my colleagues know from my research and other colleagues' research that we're just putting too many people on dialysis and putting them on unnecessarily, putting them on way early. And we'll get to that a little bit today. Now, that's one of the reasons I wrote the book. And then I also realized that so many people are being overdiagnosed with kidney disease. And that's something else that we're going to talk about a little bit today. But we'll try to focus on, the issue of if your kidney function's getting worse, what do you do? And what does it mean? So we can dig right in if you're ready, James.
Sounds great. Let's get going.
All right. So many of you may have heard about the stages of kidney disease, the 5 stages, just whatever. There really aren't 5 stages, by the way. and the 5 stages were basically a way to talk about different levels of kidney function. That's all they are. There's nothing magic. And so what we're going to talk about is those of you who have kidney function number. That's called your eGFR, or your estimated kidney function, estimated glomerular filtration rate, eGFR. We'll talk to those who have it over 60, a number over 60, and it's declining from over 60 levels. And what do they mean? If it goes from 90 to 60, does it mean anything? And then CKD3, which is the vast majority of you, which is around 30 to 60 EGFR. And then we'll get to those of you, it's much smaller numbers, who have CKD4, which is 15 to 30 on the GFR, and 5, which is less than 15. These are just arbitrary divisions, frankly, in many cases. And the one thing that I'm really, really against is the fact that they call CKD5 kidney failure. Big mistake. And we'll talk about that in a little while. Okay. So, what about those of you who may have had a GFR over 60 that declined? Is that something that should be of concern? And I hope you don't mind because I quiz James a lot because I want to make sure he's paying attention to all of these talks that I'm giving on his show. Any idea about that? If you go from 90 to 60 or 80 to 70, or what does that mean?
That means you need to get a second test.
Absolutely. That's great. That's great. So, what us kidney doctors decided is that when you are at levels above 60, the values are not worth a damn. So, forget about them. As they say, forget about it. You know, do we always forget about it? If they're over 60, all people should forget about their numbers over 60, James?
Nope, not if they have a lot of protein in their urine or other indicators of problems.
Yes, yes. You've got protein in the urine that's significant, which we'll get to, or even blood in the urine, or maybe some cells in the urine. But if you just have a normal urine and you're over 60, we don't consider it kidney disease. So let's say that you've got a number that's 55. Is that definitely kidney disease when you just went to your doctor, you came home and your number's 55? What needs to be done? What does your doctor need to do?
Well, first, how old is this person?
We're going to get to that. I'm not up to. James is getting ahead of me. Go ahead.
Well, the doctor, 55 means there's reduced kidney function, but they still need to do a second test
Yes,
to
right
follow
there.
up on the numbers because it fluctuates
Yeah, and
all the
so
time.
absolutely, James. And what's been decided is that we will not call you to even have kidney disease, assuming you don't have an abnormal urine with protein or blood or what have you, if you don't have at least 2 tests 3 months apart, and you got to have a value less than 60. So that's to get into the diagnostic category. All right. So and very, very, very often your second test will be normal. So
Mhm.
don't panic if you've got one value below 60. Um, so what is the first thing that a lot of your folks that listen to your show, when they hear they've got a EGFR that's called CKD3, A or B? By the way, 3A is 45 to 60 and 3B is 30 to 45. What is the first thing that you hear from them?
Well,
What the
it's
first
always
one?
the first question. There's a lot of common questions, but it's
Yeah.
what do I need to eat? What do I need to do? Do I need to eliminate potassium? They're reading a lot of information that's for dialysis patients and applying it to themselves.
Well, I think that this is the thing I'm getting at. They worry about what I have seen in my experience, and I'm sure you've seen it too. They worry about, am I going to have to go on that dialysis machine?
Yeah.
And the reality is that if you're CKD, certainly 3A, maybe 1 in 1,000. So it's not something that you should sit around and worry about. It's very, very unlikely that you're going to need to go on a kidney machine or need a kidney transplant, especially if you have early CKD without significant protein, which we'll get to. And okay, James, we have to tell people. I know most of your regulars know this. What is EGFR? It's an estimated kidney function, and it depends on what lab test, James?
So it is, well, it's measuring creatinine, which is a natural byproduct of muscle. It is not a bad guy. It's just a cheap and easy way to measure and get an estimate of your kidney function.
Yeah, yeah.
Is that what
So,
you were looking for? Because
yes,
people are
yes,
always trying to
exactly.
figure out how to
Exactly.
reduce creatinine, which is not the problem.
Yeah, James has that on the head. You're going to see things online. Oh, this is the best thing for you to do. A kidney enemas or kidney cures. We're going to get your creatinine down. It's nonsense. Drink a lot of water to get your creatinine down. It has nothing to do with how your kidneys are functioning. Creatinine is just a marker, as James said, it comes from muscle, and it's just a convenient way for us to plug it into the estimate. It's just an equation of your kidney function. Now, what about people have a declining estimated GFR and they're 3A, 45 to 60? Is it always a worry? And when may it not be a worry?
So it's
Your
definitely
opinion.
not always a worry. But we
Okay.
want to look at the trends, not the individual numbers. And I wish they would not give numbers, but instead give ranges. That's just my personal preference for that. It's most likely the most common thing could be dehydration, could be medication you're taking. It could be a lot of things that are causing it to go down.
Well, what I was getting at, James, is something that you talked about earlier. James was talking about the fact that as we get older,
Mhm.
the expected kidney number is not going to be the same as when you were younger. So it is very common, and this is what people in Australia and New Zealand did, which I think makes a lot of sense. In their guidelines, if your kidney number is over 45, which would be 3A, 45 to 60 is 3A, and you're over 70 years of age, and you don't have significant protein in the urine, they don't even consider that to be CKD. So if you're an older person and you're in the 45 to 60 range and you're bouncing around in that range, it may not mean a thing, especially if you are not spilling protein. Now, and one of the reasons for this is that as we get older, it's less likely that you're going to have protein in the urine compared to younger people. Now, everybody wonders, what is the significant protein in the urine?
Mhm.
How do we determine that? And that's an important thing for everybody to know. Um, a lot of people, and I did a lot of research projects where they were looking for something called microalbumin, which is small amounts of protein in the urine. Albumin is one of the major proteins that we look for kidney disease, albumin in the urine. Microalbumin, if you do dipsticks, a lot of you folks have been to the doctor, and some of you may have listened to our talks where we talked about buying your own urine dipsticks. They're cheap. You can
Mhm.
buy them on Amazon. And they're really good for you to have if you want to follow your urine protein. I highly recommend it. But microalbumin is like trace. And to me, that's not real proteinuria, not something to get excited
Mhm.
about. Part of the reason is one day you may have some microalbumin, and half the people, when you check it again, you won't have it at all. It's very variable. It's affected by a lot of different things, including fever, medicines, infections. So that's not significant proteinuria. Significant proteinuria, they use a big word in kidney docs. They call it macro protein, which macro means a lot.
Mhm.
And James, as we've discussed many times, the best way to get a good idea of how much protein is in the urine is to do what? I hope you remember that.
Your it's uh the ratio, the albumin, creatinine albumin ratio, ACR.
ACR, albumin,
Yeah.
A is for albumin, that's the protein. CR is creatinine. The ratio of albumin over creatinine. So you have a little bit of urine in a little tube. The lab takes it and they check the albumin, like it's also a blood test, and they check the creatinine in it, which is also a blood test, but they test it on your urine. And that ratio in the United States, over 300 is certainly significant. I would say over 200 is even significant. And the reason why I use 200, because a lot of the research studies, when they look at people with significant proteinuria, the cutoff is often around 200. If you're outside of the U.S., and I don't want to bore you with the units, you divide by 10. In Europe, they use different units. So instead of 300 or 200, it would be 30 or 20. Okay, that's significant protein in the urine. Another way to do it, if your dipstick is consistently 1 plus or more, you've got significant protein in the urine. Without going into the mathematical explanation, get your urine checked. If it's consistently 1 plus or more, certainly, like if it's 2 or 3 plus, for sure. But even 1 plus consistently, you probably have significant protein in the urine. And your doctor can confirm it by doing that test of the urine. And if you happen to be an older person with CKD3 or even CKD4, you may have that level of, and James is one of these folks. He's got CKD4, right? And you can have it easily for 10 years,
Oh yeah.
without it changing. So don't panic, and let's see what else you need to do besides that. So now let's get into, if you have a declining GFR and you don't have significant proteinuria, and you still have abnormal kidney function, and your kidney function is declining, what's the main thing you need to focus on, James? Do you know? I mean, what's your main concern? Yeah.
Is that managing my blood pressure and making sure I'm taking care of my heart?
Yes. The fact of the matter is, especially for older folks, there's lots and lots of us, I'm an older folk myself, that have an abnormal estimated GFR, don't have significant protein in the urine, but that abnormal lab test is saying you're at a higher risk of having a heart attack, having a stroke, having heart failure. So your main job is to decrease that risk. If you're in that range of 3A, 3B, or even 4, or even 5, you certainly need to decrease that risk. But for those of you 3A, 3B, that's the main thing you got to do. No protein in the urine. Figure out ways to decrease that risk. And James already told you one of the most important ways: blood pressure control. Absolutely, blood pressure control. And you want to try to get your top number to be 120 if you can. If you're older and you have trouble sometimes having your blood pressure a little too low, you can go 130. But I would say 120, if you can tolerate it. Important for your heart issues, as well as slows your kidney decline. So that's very important. Another thing in today's world is there's game changer drugs that I've talked about on several talks with James. And one of the types that has been studied the most is called what, James? Do you remember that? The type of drug begins with an S.
Yeah, SGLT2s.
You got it, James has got it. Yes, James, yes. These are the gliflozins. And so I'll give you brand names because a lot of people just go by brands. There's Invokana, Farxiga. I don't know. How do you, Farxiga? How do you pronounce that?
Farxiga. I've seen
Is
their
that what?
commercials.
Farxiga. Okay, Farxiga. And then Jardance. Okay. And their names are Empa, Cana, Dapagliflozin. Just know that these SGLT2 drugs are extremely important, especially if you've got an abnormal kidney number and you've already got a history of some heart problem. You're diagnosed with heart failure. You've been diagnosed with having chest pain, angina. You've been diagnosed with having TIAs or strokes, transient ischemic attacks. And if you've had any of these diagnoses, for sure, you're at an increased risk of dying, especially with your decreased kidney function from one of these heart-related, blood vessel-related issues. And these drugs are important if you can get them. Usually you can get them if you're diabetic. I think that the insurance companies should also allow you to get it if you've had one of those cardiovascular problems. The other drugs that we talked about last time are the weight loss drugs. There's more and more evidence that they may help your kidneys and your heart. And a lot of folks say, okay, I'm diabetic. I want to get my A1C to 7, and that's going to help me live longer and protect my kidneys. Is that the case, James? Do you know?
Not always.
Yeah, I would say this. I would say if you're a young person, and especially a type 1 diabetic for sure, control of sugar will have an effect on both your kidneys and your risk of dying of heart-related stuff. If you're an older person, you're much more at risk of having low sugars, which could be deadly, called hypoglycemia, if you go to an A1C of 7. Shoot for an A1C of 8 because you're not trying to get tight blood sugar control, especially for an older person, because it will not help you with regard to your kidneys or your longevity. Now, what if here's the big one. If you've got a decline in your kidney number and you've got significant protein, as we just discussed. And this happens much more commonly in those people with CKD 4 or 5. Much, much more common than CKD 3 folks. But either way, if you have a decline and you've got significant protein, what do you got to think about there, James?
So I want to make sure I'm on an ACE or an ARB.
Yes. Okay.
Yep.
Exactly.
Which is a
Exactly.
very cheap, common blood pressure medication.
Yeah. Exactly. Exactly. So here's one of the main messages. Research has shown that reducing the protein in the urine, in this case it's the albumin creatinine, reducing that should be your main goal. Your main goal. Because this can lead to slowing of kidney function loss. Again, the main goal, if you're one of these folks with significant protein in the urine, especially if your GFR is declining, is to get on drugs that can decrease the urine protein because that can slow your decline. Very important. And James is right on. ACEs or ARBs, very cheap. Number one thing. Also have great benefits for your heart, for heart failure, for heart-related deaths. First thing you need to be on is one of those, ACE or an ARB. And James will tell you how to identify them.
Yeah, I can never remember which one's which, but one ends in tan, the other one ends in pril, like lisinopril, losartan.
Yeah, the Losartan, the TANs are the ARBs, the PRILs are the ACEs. And we've talked about this numerous times. But they're very important, and they're great drugs. Everyone with high blood pressure should, at least your doctor should consider you to be on at least an ACE or an ARB, and that may help you for your heart issues, and certainly if you've got significant protein in the urine.
And my
And
favorite part
then,
is they're affordable. And
very
my
affordable.
insurance covers them 100%.
Yep, yep. The next ones are the ones we just talked about, the SGLT2s. Lots of evidence that they can, like the ACEs and ARBs, protect your kidneys, slow decline of kidney function. So, and they're worth the money. I mean, if you're one of these people with a lot of protein in the urine, or if you're one of these people with heart issues, they're worth the money. If you don't have heart issues, you don't have a lot of protein in the urine, probably not worth the money. Okay? But I would say if you're one of these people with significant protein in the urine, the ACE or ARB, your doctor should at least consider adding an SGLT2. And it is possible in the future, as the drugs get cheaper, that you may add a GLP-1. The research on that is just beginning to come in, the weight loss drugs, okay, the Wegovy's and stuff like that. We talked about that, I think, last time I was on your show. And the other drug, which is extremely expensive, which I don't particularly advocate, it's called finerenone. And you could take an equivalent drug, which is what James is on, spironolactone. It's a very, very, very cheap drug. It's pennies.
Mm-hmm.
So these are drugs to consider you discussing with your doctor if you've got significant protein in the urine, and you want to look for that amount of protein to be reversed, and that's a really good sign, because that's a good sign that you may be helping your kidneys from going into kidney failure.
Yeah, I like to think of it as you're applying the brakes to your drop in kidney function. So hopefully you're applying it enough to where you never have to worry about getting to the point where you need dialysis.
Yeah, yeah. Well, I mean, uh, and 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 again, well, we'll get into this in a few minutes in terms that issue of getting to more advanced and the dialysis thing. That's going to come up in a minute. Um, Now, can your declining EGFR, and these especially goes for people like James, and he had a really good example.
Mm-hmm.
Can your declining kidney function be reversed, even with CKD4 and 5? And James knows the answer.
Yeah, so there are two types of kidney problems: CKD, which is chronic kidney disease, and there is AKI, acute kidney injury, or AKI, yeah, acute kidney injury, which is a temporary thing, could be dehydration or something like that. And you could have CKD with an AKI that will plummet your estimated kidney function really, really low, which is what happened to me. And they wanted to put me on dialysis, not realizing that I also had an AKI. We got that taken care of, and my kidney function started to increase, but it only increased so far.
Well, and I'll say this, James, and I've seen this over and over again. If you've already got CKD, your EGFR is abnormal. You go in the hospital, you're usually sick. You may be nausea, you may be
Mm-hmm.
vomiting, you may be bleeding, you may be dehydrated, you may have low blood pressure, for various reasons. Your heart may be weak, you may have heart failure. It is almost guaranteed that when you go in that hospital, your kidney function is going to get worse. It's going to get worse. And you need to see if it can recover. Unfortunately, especially if you're already on the ACEs or ARBs, because they tend to potentially make kidney function worse when you get dehydrated, or you're on drugs that you take for fever, like NSAIDs, like Motrin,
Mm-hmm.
and so forth. So um, it is not it's fairly common that your kidney function could go back to whatever your pre-hospital number was. And what happens to a lot of you folks, especially older folks, you get in the hospital, you get sick, you may have heart failure, you may have one of these other things, and the doctor says, well, you've gone from a GFR, let's say you're CKD4, right? You've gone from a GFR from 20 to 10 or 12. We want to dialyze you. Put on the brakes, folks. Put on the brakes. Put on the brakes. You may be one of these situations like James where they try to put him on dialysis when he really didn't need it.
Mm-hmm.
So you want to ask your doctor, say, hey, doc, I know that my kidney function is worse, but maybe it'll get better. Can we wait a little bit? All right. And I highly recommend any of you that have kidney function in the CKD4-5 range, let's say 15 or less, or even 15 to 30, um, that you please look at my book, look at the section about when to start dialysis. Because, again, one of the reasons I wrote the book, I was recognized in my field as doing a study that was considered number one game changer in my field. And that's pretty big deal, right?
Yep.
What did my study? It was a very large study, and what it showed is that starting dialysis early may be harmful, not neutral, harmful. Okay. And what did we mean by early? Over 10, roughly over 10. And what did it seem from this particular study of a large number of patients in the U.S. That starting below 5 was the best
Mhm.
situation. Now, a lot of you are not going to be able to get that low, but so many people are starting at 15 or more. There was a nursing home study that found 1 in 5 of these older folks in the nursing home were put on dialysis over 15 eGFR.
Oh,
And guess what? They didn't even have a good reason to start. Very, very, and that's, again, you could see what got me motivated to
yeah.
try to prevent that from happening. All right.
And when they're older, they're
Yeah.
likely to pass from something else, not kidney
Yes,
issues. So they're put on the
absolutely.
machine, their quality of life plummets, they're at risk of infection, they're
Yep.
not feeling good, it's bad on the, or it's tough on their heart.
Yep.
Oh,
Yep. Yeah, that's, and I mean, hopefully, um, as a result of my research and my colleagues that have shown that this is not beneficial, hopefully that's not happening as much. And I think there is some trend in the data to show that people are starting a little bit later, but not a lot. Still, a lot of people are starting early. A lot, especially older folks, especially in the U.S. Um, so, what if it's CKD45, but it's not AKI, not what we just talked about? It's not reversible. Aha! Now you got to figure out, what do we do then, James?
well, we're going to take the medications. I'm, address any protein in the urine, keep my blood pressure under control. I'm going to eat a heart healthy diet, stay active, stop smoking or any of those bad habits. Hopefully, I've stopped those before. Is there something else you're looking for in particular?
Okay, well, let's break it down by younger and older folks.
Oh,
Okay. If you're a younger person, somebody already put something up on the screen addressing this, and you got an EGFR in the 20 range or less, you're eligible to be put on the transplant wait list.
yep.
And that is extremely important because you may have to wait years to get a transplant from someone who dies and donates a kidney. Now, just as an aside, I just mentioned to James, there was a successful pig transplant today to a healthy recipient, and let's hope that this is going to last a good while. The prior attempts at transplanting from animal to human, they've had very sick patients, and the outcomes weren't good. This patient is much healthier, and we'll see. And if this works, in other words, they treat the kidney of the animal in a way to make it extremely unlikely that it's going to reject.
Mhm.
Anyway, get on the list. And if you're a younger patient, don't be hesitant to discuss, I may need a kidney in the future. I don't know if any of my relatives would even consider it. I think, we'd like to talk about it. I mean, and there's a lot and actually James has had someone on his show that's an advocate of trying to get people, even
Yep.
unrelated people, to donate their kidneys. Okay. So yeah, but here's the deal. You don't have to be related to somebody to get a great outcome from kidney transplant. So if you've got friends or relatives, at least look into that. The next thing is, if you are going to think about going on hemodialysis, which is the blood type of dialysis,
Hmm.
you will need to get something called an access. The access is where they get your blood from in your arm, um, and they connect an artery and a vein. I won't get into details tonight. It's in my book in detail. But here's something: if you're an older person, don't rush into this, because there are so many people that die before they ever really need to
Hmm.
use that access. If you're a younger person, sometimes the earlier the better. If you know you're not going to have a kidney transplant, You're not going to go on the dialysis that is called peritoneal, goes through the belly, where fluid runs in and out, usually while you're sleeping. You're going to go on a hemo program. Yeah, I would get the AV fistula relatively early, at around 15 or 20, uh, because the longer they're in, the better they become. And even more importantly, you've got to save your non-dominant arm.
Mm-hmm.
And don't let them stick needles in it, because that's the arm that they're going to use for your access. Your non-dominant arm means if you're left-handed, it's your right hand. If you're right-handed, it's your left hand. Okay. And again, I would not rush into it if you're an older person. If you are not sure whether you're going to be willing to go on a machine, they can always put a catheter in your neck if you, at the last minute, are really sick and you need to go on. That could be your way to get dialysis. Now, what should be the reason if for you to even need to go on a machine? And this is not what's happening in a lot of cases. What should be the main thing that will be appropriate for you to be saying, okay, doc, this is happening, so I think maybe I should consider going on the machine? What is the issue?
Is it when it's when they can't control the symptoms with medication, like retaining
Exactly.
fluid, bad for your heart, your lungs?
James, you hit it. It should be your symptoms should be the primary determinant of whether and when you should go on a machine, which is not the case, by the way. Doctors all over the world are just saying, hey, you got a kidney number of 10 or 12, you go on a machine. you know, it should be your symptoms. And
Yeah.
most of the symptoms can be managed without dialysis. And as James just said, one of the biggies is anemia, low blood count, low red blood cell count. Easily managed with this injection once a week, once a month, and you'll feel so much better. And some people have fluid problems. If you take the right diuretics and you use the right amounts, most people's fluids can be controlled. And then there's potassium. Sometimes people have potassium problems, and those two can be controlled with 3 current drugs. And so, again, my thing to you would be, hey, doc, can we treat my symptoms without a machine? Let's give it a try.
Mm-hmm.
And please read my chapter about the early start issue, and discuss it with your kidney doctor. The other thing that you need to do, again, if you are CKD4/5, it's not reversible. It's not getting. It's not going to get better. It's going down. Talk about the various types of therapies, which are dialysis and transplant. And again, in my book, I go over in great detail the advantages and disadvantages of getting kidney transplants, what you need to do to get it, and different types of dialysis. The one where they have a tube in your belly called peritoneal, and the one where they just take the blood out of your vein and put it through the machine. That's hemodialysis. You can do these at home, or you can do them. The hemo can be at home or in a dialysis center, which are all over the United States and all over the world, where they have the kidney machines. And the one through the belly, the peritoneal dialysis, which I personally recommend, because you can avoid the needle sticks and you can do it at home, is one to at least consider. And as James said, a lot of people say, "Oh my gosh, I'm sick. I should go on dialysis." A lot of docs are not going to tell you what the downsides are, and there's many downsides. After dialysis, a lot of people feel washed out.
Mm-hmm.
If you're an older person, you're probably going to not be able to get around as well. People lose their ability to move and function as well. And your mental function may also go down, which is not uncommon. And it takes a lot of your time away. I mean, as we get older, our time becomes precious. We have less and less time to be on this earth, and you if you can avoid spending the majority of your time going back and forth to dialysis, that would make a lot of sense. So you don't want to rush into dialysis.
And the dialysis process is very lengthy if you're going to a center, getting it done, coming back.
Yeah, on average, it's going to be about 5 hours of your day, at least 3 days a week. And that's excluding problems with the access, which become a problem very often, and you may have to be hospitalized for that. So no rush into dialysis. If you really need it, it could be life-saving. There's no question about it. And a lot of people that are put on dialysis not for the serious issues. They're put on because they feel a little nauseated, their appetite's not so good. Those aren't great reasons to go on dialysis. So, and the other thing is, this used to be a very big thing. So someone says, well, I'm not eating well, I may be losing weight. And it turns out that dialysis actually does not improve your nutritional state. So if you got severe nausea and vomiting, maybe you should go on dialysis. And there's no other cause. But you want to share the decision with your kidney provider. And most people don't. The doctor says, oh, you need dialysis. And they go, okay, well, when do I show up? Don't do that. You need to decide with them, and decide with them after you're educated. And again, I go into great detail about educating you about this dialysis stuff in my book. And a lot of people have no real reason to go on dialysis. Again, ask your doctor, can we treat it without dialysis? Can we treat it just medicines? And what's the reason why you think I have to go on it? And some of you, especially as you get older, and there are people getting on dialysis in their 80s and 90s, you may not want to experience the pain and all of the time that it's going to take.
Mm-hmm.
Tell your doctor what's important to you and whether or not you really should go on. So, as we said earlier, if you are not able to control your fluids, and I find a lot of docs are not good at using diuretics. They're afraid. They don't use enough. But hopefully you get a good kidney doc that can get your fluids under control without dialysis. Sometimes they can't. Sometimes they can't, no question. And sometimes they can't control your potassium. But there's several drugs out there to control potassium these days. And like I said, if you've got a lot of nausea, vomiting, no other reason, and you've got, CKD5, GFR is in the 10 range or less, that may be a reason to go on dialysis. And I'll just put one plug in here. Can't resist. We talked about what to do if your kidney function is declining. Please do not go on these very low protein diets, because that is a good way for you to die sooner, frankly. And don't fall for those amino acid supplements and very low protein diet. Your nutrition gets worse as you get worse kidney function, and you want to preserve your nutritional status. So you want to, at most, have a reduced protein diet. In the U.S., it's like about a third of your weight. So 210 pounds would be about 70 kilograms of protein diet. And those of you who understand kilograms, it's 0.8 grams of protein per kilogram of body weight. And I think that is enough conversation, and we can answer
Time
some
to answer
questions.
some questions. Yeah. All right. There are a lot of questions in here, Doc.
Okay. Do you have
I
any
hear
questions, James?
I hear a little bit of feedback, so I'm going to try to let you find the questions. But what about someone who is on dialysis that feels they were started too early? How can they have a discussion with their doctor about seeing if maybe they can come off dialysis? Because we always get that question.
I have personal experience with several people who have done that. And you've got to have a willing kidney doctor. And the fact is, it's challenging and it's time consuming. But you can have your labs monitored, your blood pressure monitored, your weight monitored. And here's the key thing. If you're putting out a good bit of urine, like a half to a liter of urine a day, a liter is about a quart of urine. If you're putting out that much urine, there's a good chance that you can do okay without a machine. And there's a way to get your kidney function after you've started on dialysis. The way that can be done is you just have to not be on it and have your blood monitored, your levels of potassium and your fluid levels and your blood pressure levels and so forth. And you could see what your kidney function is after you have to be off dialysis for, let's say, a week. And then you can recheck EGFR. And you can actually do it even while you're on dialysis, but a lot of doctors aren't going to bother with that because that involves collecting a lot of urine in between treatments. It's a little complicated. But it can be done. And like I said, if you've got a half a liter to a liter of urine that you're still making, that's a consideration. A lot of docs will not even look into it, but it's worth considering. And the big thing about that is, let's say you're making a quart of urine a day, which means you still got kidney function.
Yep.
And all of the research, the factor that shows the best prediction for how long you're going to live once you've been on a machine is how much residual kidney function you've got. Not how fancy your dialysis is, not whether you do it, 3, 4, 5, 6 hours, not whether you do it 5 days a week or 3 days a week. It's what your residual kidney function is. And what this tells me and some of my colleagues is that your own residual function is much more valuable than any machine can ever give you. And unfortunately, going on the machine, that residual kidney function is going to decline. So anyway, that's my answer for that. All right, James, do you want to pick any out? Or?
I'll let you start looking for them, and as I'll find them as you talk about them.
Well, I'll start from the bottom here. Swelling in the ankles. Should you use compression socks? Okay. Well, Lindsay has swelling in the ankles and wants to know if you should. Swelling in the ankles, which is also called edema, and the easiest way to tell if you have edema is take your finger and press it into your ankle and leave it there for a while. And when you lift your finger up, if that indentation remains, that's edema. You got excess total body salt and water. That's what edema means. And in terms of treating it, it depends on what the cause is. But it's probably reasonable to try a diuretic to treat the edema, especially if you are a kidney patient. Okay. And Vincent says, make sure you let them know about a proper diet can help with CKD. Okay, here's what I will say. And James has a dietitian who's very good on his show, Jen, and I assume Jen is in agreement. Plant-based diet, a Mediterranean diet, mostly plants, no packaged foods, avoiding what you can on the terms of packaged foods, a relatively not very low protein diet, which we just discussed, is the best thing for your being a kidney patient. Because again, the majority of you, the vast majority, probably over 90% of you, it's not kidney failure that is your concern. It's dying from one of those heart-related conditions. And heart-healthy diet, plant-based diet is what we think is definitely best for you. Okay, here is there any correlation A1C and EGFR? No. Well, look, that's a really good question. This gets very complicated because there's type 1 diabetics and type 2 diabetics. As I said, the data on young people that can control their glucose well which is what the A1C is. It tells you how well you control your sugar. That can prevent you from getting diabetic eye disease and diabetic kidney disease. Once you get into your 40s, 50s, 60s, and on, that is very, very little evidence that they relate. Tighter glucose control and better kidney function. Younger, yes. Older, probably not. Okay. Anyways, and then, okay, call anyway. Does the prostate affect kidney and urine protein? Okay. In men, if you have an enlarged prostate, it can result in blockage of your urine passage. So that could be what they call obstructive uropathy, blocking your urine flow, which can cause kidney failure. And if you are a man and you have urine problems, you're dribbling urine, it's not emptying out, you feel full above your where your bladder is, get it checked out. And there's lots of things that can be done for men to help the flow of urine. And that is definitely a potential cause of kidney problems, blockage by the prostate. Okay. Does sodium bicarbonate make you urinate more often? And does that affect your sodium intake? Well, okay. So sodium bicarbonate is sodium.
Yep,
And
quite a bit.
And there is a relationship between your blood sodium and how thirsty you are. So that is the answer to that is probably yes. And the big sodium bicarbonate we thought may help slow kidney function decline, but unfortunately the evidence is not there yet. I would still recommend it if your lab test, which is called the HCO3 or the bicarbonate, if that level is, let's say, below 22 or so, or that I would recommend it because it may help protect your bones. It may help as well slowing your decline of kidney function. So it's worth considering. And somebody was making a lot of urine before dialysis. Well, and that's typical. That's Candy. Candy was making a lot of urine before dialysis. And as we discussed, one of the reasons why I advocate delaying dialysis is because, again, your own kidney function is very valuable for your longevity, for your overall health. And again, the kidney machines cannot do as well as what your own kidneys do. And you will lose, as happened to Candy, lose whatever urine you're making as you've been on dialysis for a while. Go ahead, James. You want to say?
There was a question about Losartan and lowering or seeing a drop in your kidney function when you start that. Can you talk a little bit about that?
That's a very, very, very important question. And a couple of talks ago, I mentioned that I was asked to review a couple of papers, which is interesting. I still got my hand in the academic world for one of the prime kidney journals called Kidney International. Anyway, long story short, they said, how do we interpret whether or not these drugs are really benefiting us when there could be an initial decline of kidney function when you start them? And whether it's an ACE or an ARB, okay, the prills or the TANs, Losartan, captopril, and allopril, or even the SGLT2s, okay?
Hmm.
Those types of drugs can cause an initial drop in estimated GFR, your estimated kidney function. What the kidney docs have decided, and this hopefully is the correct answer, is if you're one of those people with significant protein in the urine, as we talked about earlier, it's worth continuing them unless it drops more than, this is an arbitrary enough figure, drops more than 30%. That's a lot from your baseline.
Mm-hmm.
Because the thought is over time, over years, they still are are likely to have a beneficial effect to slow decline of kidney function. But that's an important question, and there's been indirect evidence that the people who stopped the ACEs or ARBs actually did worse. They have more likely to develop kidney failure and more likely to die of a heart-related condition. So it's not a clear-cut thing, but if you have significant protein in the urine, I would say it's probably worth discussing it with your doctor and maybe continuing them. That's not an easy thing to resolve. Here's someone with GFR 21, heart attack, survived, heart failure, heart function 15, heart weak, low blood pressure. Yes, this is a extremely complicated patient, and you know, your heart is very weak. The main thing is, I would totally focus on your heart, because your kidneys, with this degree of heart failure, your kidneys are pretty much irrelevant with regard to your kidney number. I would not focus on that at all. I mean, I'd certainly treat your anemia if you've got a low red blood cell count, because treating that can make your heart working better, and it's going to be heart failure treatments with regard to the medicines and the especially the diuretics. Kevin has an ACR is 58. I'm not sure what that is. I'm not sure. I'm not sure. Yeah, I'm not sure what your ACR is. Is it 58, and are you in Europe? As we said, that would be significant. And the PCR is 682, so my guess is the 58 would be a 580 if you were in the United States. So that would be significant. So yes, if that is the case, if I'm reading it right, well, first of all, the one thing we didn't talk about earlier is significant protein in the urine, declining kidney function. When we talk about the ACE or an ARB using the maximum dose, I think 100 is about maximum for Losartan. That's the first thing. And if you're still spilling it, SGLT2 for sure. Yeah, I would say yes.
All right, we got time for one more. We're at the top of the hour.
Okay, all right.
Who's going to be the lucky person?
This is about health plans. Okay. Anyway, dad 6'2", diabetic nephropathy. Creatinine came out 8, GFR 7s. Okay. Well, look, tenacity. You're talking about, for sure, GFR in the 7 range. As I said, you're close to that theoretical ideal 5 number. For sure, there needs to be preparation for dialysis, and you're certainly getting close. And all the things we talked about with regard to looking at my book of types of dialysis, considering transplant, getting on transplant lists, and having transplant donors, it would all be applicable. But you want to get as much of the symptoms treated medically before the dialysis is started. But you're getting close, no question.
Yeah. All right. That has been a fantastic and educational hour, Dr. Rowe. And I feel good. I answered your questions. I didn't miss any. Yay! Sometimes I worry you're going to make me say that word.
You did good, James. You did real good.
For a type of heart disease that is kidney disease is a major risk factor for. I'm glad I didn't have to say that. But thank you so much for giving us your time and your knowledge here. And for everyone else, if there is a lot more information available in Dr. Rowe's book. And it's always a pleasure to talk about his book. First of all, because I believe in it. And, he's donating his time or volunteering his time to help all of us. His book is called Learn the Facts About Kidney Disease. You can purchase it at Amazon or any bookstore. So if you've got a mom and pop bookstore near you, they would love to order it for you. It's an easy read. It's understandable. It's not written complex. Dr. Rowe uses normal English that we can all understand. You don't need a medical thesaurus to figure out what everything is. And I feel that's how a lot of the books out there are. They get so technical. Like, oh, what does that mean? Do I need to worry about this? Dr. Rowe makes it simple. All right, Dr. Rowe, thank you so much. This is the last scheduled broadcast for 2024. I am now off of work for the rest of the year. Luckily, I work in the automotive industry, and that's kind of the way it is. Things close down. You get the last half of December off. I'll probably do a couple little broadcasts myself, talk about some things. Dr. Rowe will be back here in 2025. Jen Hernandez, the renal dietitian from Plant Powered Kidneys, will be here. And there are some other people that I'm working with to get them scheduled to talk about other devices that are soon to come on the market to help monitoring things for dialysis patients or those that are very low in kidney function, and so much more planned for 2025. So please like the video, share it. We love seeing your guys' support and the numbers going up and up and up. Dr. Rowe loves to see his videos get huge numbers. So let's make it really, really big for Dr. Rowe. And it's always kind of, to me, it's nice to open up and go like, wow, look at that one. 100,000, 500,000, 1,000,000 views. Wow.
Yeah, well,
You know, I haven't looked, Dr. Rowe, at the one we did talking about how to reduce protein in your urine. The last time I looked, I think it was 800,000 plus views, but that was probably 3 months ago. It might have broke 1,000,000. I'm going to have to check and let you know during our next call.
that sounds good.
All right. Thank you, everyone. You all have a great rest of the year. Have a happy holiday, a fantastic new year, and we will see you in the next video. Bye, everyone.